All right, folks, welcome. We're going to let people stream in. And welcome to This Clinical Life, our monthly webinar talking about all things of getting through on our feet, the life of providing care to others. And my name is Stephen Beeson. I am a family medicine physician and founder of Practicing Excellence. And I'm here with a really dear friend of mine. There are rainmakers in life, and Corey is a rainmaker. His wife, Jennifer, is a real rainmaker. And he has made a profound impact through a very dark period of their lives, in the lives of tens of thousands of clinicians across our country. So I'm deeply grateful to Corey and for your advocacy, for your friendship, for all you've done to advance the well-being of clinicians. So Corey, welcome to This Clinical Life.
Thanks, Steve. It's amazing to be here again with you, and just to create some space and time talking about important subjects like this is just, it's what I do. So I'm really happy to be here with you. Thanks for having me. So
I want to begin with you describing a little bit about the Lorna Breen Heroes Foundation and the work that you've done, and even your press release today that I saw, sort of encapsulate what the general mission is of the Lorna Breen Heroes Foundation and sort of what progress you're making, and hope for the future for all of us that are listening.
So I'm glad we have 5 more hours for this live streaming session to answer question 1 for you today, Steve. No, thanks. We created the foundation just a little over 3 years ago, and it has had a profound impact so far. Our numbers are growing in terms of our impact numbers. Our stories we're hearing are growing. We started out of the tragic story of the loss of my sister-in-law, Dr. Lorna Breen, and it was really the stories we heard from healthcare professionals who all had this consistent refrain of enough is enough. And when Lorna died, I had been the CEO of the UVA Physicians Group, which employed all the advanced practice professionals and physicians who practiced in the health system in Charlottesville, Virginia, where I worked, which is UVA Health. And so I was very attuned to the operational challenges that were driving burnout. In fact, we had a lot of interventions that we were working on then. But what was hidden in plain sight from me was the stigma around mental health and the structural stigma that obtaining mental health really is reinforced by for licensed healthcare workers, these overly invasive questions that really plague them and punish them in many cases for getting mental health treatment. So, our foundation has been incredibly focused on the healthcare population, the healthcare workforce population, not just one segment, but the population of healthcare workers, looking out for their well-being and focusing on decreasing their burnout and increasing their job satisfaction. We envision a world where seeking, and I would say, and obtaining mental health treatment is viewed as a sign of strength. So we've had tremendous impact and success so far. And I just want to maybe pause for a moment and say that while there are so many issues here and so many potential solutions, one of the most impactful things that we can do is what we're doing today, which is to simply speak about the unspeakable. I was recently quoted as saying, when the unspeakable happens to you and you speak of it, it gives others permission to speak too. And what is really probably the very first thing we all need to be doing is what we're spending time to do today, which is just talk about these issues, talk about the challenges, and talk about the solutions, because we know that those will have a tremendous impact on supporting the healthcare workforce right now. So maybe I'll pause right there for a station break.
Yeah, and I want to go back and again, the regulatory changes that you've helped to initiate, the funding on the Lorna Breen bill. There's such a registry of movement in terms of making the lives of those providing care a bit better. I also want to talk about Lorna. I never had a chance to meet her. I feel like I know her, and I know this is an incredibly hard thing to talk about, but I want you to talk about Lorna
Mhm.
and a little bit about what happened,
Mhm.
because I think it's important for us to understand what is at stake.
Yeah,
And so if you're willing to share a little bit of
sure.
the story.
Sure. In some ways, Lorna was as unique as her name, named after a book by her parents, a surgeon and nurse. The book Lorna Doone, I think is what it was called, but I wasn't there at the time. She was a adult cellist. She went back to because life wasn't hard enough. She decided to learn the cello later in life. She was a snowboarder. She was a skier. She was a world traveler. She was the crazy aunt to 8 nieces and nephews. She was quite religious. She was living her dream as an emergency medicine physician, and not just a physician, but a leader in healthcare in a very busy health system at New York Presbyterian in New York. And I focus on the leader piece because I don't think we focus on that enough, because the pressures that she was really exhibiting and the feeling and the pressures of the stigma are not just on the healthcare workforce, but they're really on leaders as well, about showing weakness in particular with your teams. So Lorna was in some ways unique as her name. In other ways, she was a classic emergency medicine physician, right? She would go on vacation and, you know, intubate patients while she was walking to the back. I mean, we were on vacation with her one time, and she went to the ladies' room in the middle of a ski resort with us. And we're like, where is Auntie Lorna? We called her Auntie Lorna. She was like, oh yeah, somebody coded like walk into the bathroom. So I just resuscitated him. He's fine. We were like, oh, well, we've been sitting here sipping our afternoon beverages, and you've been like, I mean, I was just like, and that's just how she was. I like to say that, I always took her advice, and unfortunately I took one piece of advice from her, which has recently resulted in a surgery. So because she had that like larger than life personality, she loved adventure, and she ran the New York Marathon in the mid 2000s. And she promised me if I ran that race, it would be the best day of my life. And let me tell you, having just had meniscus surgery a week and a half ago, it was not.
Yes.
It was not. It was grueling, and it was horrible, and it's still to this day painful. But other than that, she was amazing. And and I appreciate you mentioning about the sensitivities, because a couple of things. First of all, my wife was her closest human on the planet, and Jennifer, my wife, was born to be Lorna's playmate. Her parents had two children at the beginning of her dad's medical training, and then they took like an 8-year break, and then they had Lorna, and then they were like, oh gosh, we need a playmate for Lorna. So then along came Jennifer. So they were really very, very close. And for us, this is, even though it's been 3 years, it's still like it was yesterday in some ways. So the brief story was that Lorna was with us on vacation. Like, she always tried to teach my kids to ski. And it was the beginning of the pandemic, and she returned to, in a 3-week period of time, taking care of COVID patients, contracting the virus herself, and then basically going back too early, with clearly cognitive impact of the virus, very much clearly cognitive impact. And her first day back was April 1st, 2020, and she just called us and said, I can't keep up. I've never seen this much death and dying, even though she'd been a very seasoned ER doc her whole career. And we said, take a break, but she didn't. We said, go home. You're not well enough. But she said, my team needs me, and I have to do this. And she worked 15, 20-hour shifts. She was scheduled for 10, 12-hour shifts in a row, but she wasn't able to make it through that. And I think it was about the 8th or 9th of April, she broke, and we had to medically evacuate her from New York using a chain of friends and family who drove her south towards Virginia, all the while Jennifer was driving north to rescue her big sister on the side of the highway in Baltimore, and drove her right to the UVA emergency room, where we had arranged for her to be admitted to the inpatient psychiatric unit. And the thing about that story, other than the time frame, one of the reasons why we had to do this whole chain was nobody was going into New York. New York was a scary place. It was shut down. You couldn't even get in. And you wouldn't want to have gone in, because of this scary virus that nobody knew how to take care of. So we got, this friend chain to bring her to Charlottesville. Big part of the chain was her little sister, Jennifer. And after she started to come to, after a couple of days of her first and only mental health treatment of her life, I think it's important to say, she started to say, well, now that I've obtained mental health treatment, my career's over. My license is gone. I'll never work again, because there's all this structural stigma around getting help if you're a physician. And, tragically, even though she was doing much better, she made this permanent decision to take her own life. And, there's so many, Monday morning quarterback this thing probably every day in some ways. But we think about what we could have done. And one of the reasons why we're on this real campaign to change healthcare for the better is because I think this is a preventable thing. It is 100% preventable, what happened to Lorna. And what we've come to learn now is the issues that really precipitated her suicide were really are the number one driver of suicide of healthcare workers now. Hard stop. Number one driver of suicide of healthcare workers is the structural stigma and fear of loss of license. And so we know that we can we're doing it quickly, change the rules for the better. And that's what we've been doing. The last comment I would make about this, Steve, is before you start throwing accolades our way about what we've done, I just want to point out that we were as burdened by this stigma as anyone. And it was 11 hours after Lorna died that a prominent New York paper decided, over our strenuous objection, to publish her cause of death, because we just wanted to cry. We didn't want to talk to anybody. We didn't want to share this story. We were as burdened by the stigma. But, as I've said to you before, what we've learned in this process is that when the unspeakable happens to you, when you speak of it, it gives others permission to speak too. And what we heard in response to that initial publicity around her passing was this cry for help and enough is enough from the healthcare workforce. And we listened to that and we said, now we've got to do something different. And now we have to step into this arena and stay into this arena. And so we have, and we've made a big impact. So that's the story of Lorna, and the story that will continue, because as Jennifer recently said, she said, I heard somewhere that if you keep speaking their name, they're not gone.
Well, you wonder how this beautiful healing profession that is designed to make a difference in the lives of others, to be driven by meaning and purpose, results in so much burden and weight that the only solution seems to be to end it all. And Lorna was one with an amazing story, but there are hundreds and hundreds and hundreds every year. So I want to pivot a little bit in regards to building organizational cultures where not only is there safety to raise your hand for help and all the policy and regulatory things that are important to reduce the barrier to that, but in your experience, for leaders that are listening, to say, what cultural dials can we turn to allow people to say, you know what, this place rejuvenates me. We're working hard as hell. That's not the issue, but this place rejuvenates me. From your perspective, as a former CEO, for the co-founder of the Lorna Breen Heroes Foundation, from being at the motor end plate of the disaster of what can happen when effective action isn't taken, and helping hundreds of organizations across the country, what are the most important cultural actions that we can take to help create a place that's better for care teams?
As a healthcare leader, I think the first thing we always need to do culturally is to lead with our ears, to actively listen to what the challenges are so that the workforce feels valued and heard. And I think that is one of the biggest parts of the culture that needs to change, and is a real tactical way to do it. And I'll just share with you a quick example of that. So I was recently on a panel in Aspen, and the chief nursing officer from University of Colorado Health was there, and somebody in the audience said, "So what are the key performance indicators that you are measuring in your organization to improve the well-being of the workforce?" And she said, and it was like the perfect answer, and I'm sure it's recorded somewhere. She basically said, "While we are tracking X, Y, and Z KPIs, the most important thing that our leadership is doing is they are out on the front lines every single day, asking their workforce, what do they need? And they're listening to their workforce, and they're just doing it." You know, Steve, in some ways, just like I was saying before, like one of the most simple and impactful things we could do is just speak about this. In some ways, one of the most simple and impactful things that healthcare leaders can do to change the culture and change this whole thing is to just close this thing in the front of your face and open these things and really listen. And because I think that's the piece that has been missing. And when you look at actually the data that the American Medical Association has on what drives resilience in healthcare workers, that's an R word that nobody wants to talk about anymore, but that is a word that's important. They've found with their data that feeling valued and supported by an organization drives your individual resilience, or if you're not, it decreases your ability to be resilient. So it's a big lever that can be pulled, listening. And I keep going back to that as just as if you could do one thing, and then let me just add one other thing, and then I promise I'll keep my answers shorter. Showing being vulnerable and being authentic. You know, you hear these words, but really recognizing that we're all human, and your workforce is looking to you as a leader to be a human and to understand them. And one of the best ways to demonstrate your humanity is by being empathetic. You know, I think back to Lorna's story, and I think back to the burden she felt as a leader to show her how strong she was. And her true compassion for her colleagues was, I got to go back into this fire with everyone as these buildings are falling down, almost, you know, metaphorically. But if she had been able to, if the culture had been one where she felt like it was a sign of strength to tell her teams, you know what? I'm not at my best right now. You need me at your best. So I'm going to step out of this fire right now. I'm going to come back as soon as I can be at my best. That could have, not only could it have been life-saving, but what a leadership lesson, right? And it's hard for us to do because we don't want to show any weakness as leaders, as healthcare workers, as both. But I think from a cultural perspective, it's those little things that really will go a long way.
You know, those two actions, I think, are so potentially transformative. There's a concept called a fractile. A fractile is a subunit then when multiplied and put together can create something extraordinary. You have these little fractiles. And if we create a fractile of listening and responding, 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 and that is the action and the profile and the attribute of all leaders. It's what we do. Yeah. Because it's a proxy for you matter, you count, and it brings a sense of hope that tomorrow can be better. And not everything can be fixed, but the witnessability of leaders listening and taking action means they care about me. They care about me here. They've got my back. And there's the prospect that tomorrow can be better. And I feel a sense of hope in the journey ahead. And I think the other fractile that is so important that you mentioned is the safety to say, you know what, I'm not okay. I'm not okay. And if you look at the trust literature, vulnerability of leaders may be that and modeling leadership are the two big drivers of I trust that person. And I got to tell you, as a physician, and still, I think we're better now than we were back when I trained, but our medical programming is show no weakness. I can put in the central line. I can put in the chest tube. I can take the seventh admission. It's a sign of strength, and we ratchet ourselves up in our medical programming. The more independent we are, the more self-reliant we are, the better we are, and the better we feel about ourselves, the better seniors and senior residents and fellows think we are, the better attendings think we are. And we have to shift that mindset to not only are we providing care as a team, but we've got to be able to have the safety to raise our hand. And one of the great activities that I think can facilitate that, not only just leaders sharing their story and their vulnerability, but what I call the darkest teacher exercise, which is, what's the hardest thing you've ever been through? How has it made you who you are today? And you put in a Schwartz rounds kind of style, a group of 20 people, by the second, everybody's weeping. And they understand that it's not just me. Those moments of vulnerability are when deep friendships arise. And I'm not alone. And I now feel safe to ask for help. So anyway, thank you for sharing those two powerful dials. I'm curious also about the idea. So we would say that leadership action and leadership effectiveness is a big driver of I can get through this clinical life, right? It's what we do: listening and responding, and vulnerability, in addition to gratitude, responsiveness, reduction of authority gradient. There's a lot of things that leaders can do. The other thing is this idea and this notion of community belonging and collaboration. Speak a little bit about, as leaders are thinking about, how do we advance the culture of the organization so people say, I love coming to work here, I'm willing to access my discretionary effort, and we're going to be okay. What are the things that groups can do, like clinical microsystems and others, to help the resilience, if you will, of clinicians? What are your thoughts on that?
So I, a couple things, and we've been doing this a lot in leadership retreats that we've been leading. The first is to recognize where we've been. And I say that because I hear from healthcare workers all the time that they're still going, and no one's gone back and they've looked at and just even processed what's happened over the last few years. I recently ran a leadership retreat where we did this amazing timeline exercise where we had people plot what was going on over the last few years, personally, professionally, and in the world. And they created this amazing mosaic, which was their collective story. And they all came out of it. Again, there weren't very many dry eyes, certainly not on my end, after they went through that exercise, but it allowed people to process. So I think one of the things I would just point out is, have you all taken a minute to process what's happened over the last few years? And I think that processing exercise, which we have done a number of times facilitating leadership retreats, is such an important moment just to pause. And you will find all sorts of good, bad, and ugly in that, but it just also reinforces we've all been through this pretty traumatic experience, a collectively traumatic experience for a while. So that's more on the emotional side. Another thing that I would say is making sure, understanding what the data is saying about what the healthcare workforce wants and needs. So we know that from a burnout perspective, which is not a mental health concern, burnout is an occupational syndrome. So let's know the facts. Let's understand the facts. So burnout is driven by a stressful work environment. In order to, I'll use a medical analogy, and you're a doctor. I am just watched, television with medical shows and stayed at Holiday Inn Express last night. So here I'm going to go. What we think about is, from a burnout perspective, it's just like a bleeding patient coming into the emergency room. So the first thing you do to try is hold pressure on the bleeding wound. And that is individual support in this scenario. Individual support. So what is the individual support that healthcare workers really are asking for? They're asking for confidential peer support. That seems to be the thing that they're asking for over and over again. So let's listen to what they want and let's give them what they want. They do not want any more cookie parties, t-shirts that say we're a hero, no more apps. They are all important. They're all important and play a role, but they don't fix the root cause of the bleeding, which are the underlying systems changes. So let's now understand that there's these underlying systems drivers. So as we get really tactical here, then we go to, okay, what's the big one? And there are a myriad of issues, but the number one driver of burnout of healthcare professionals continues to be the administrative burden that the healthcare workforce carries. Hard stop. So let's chase number ones. Let's chase the top. We know there's a million things, but let's go to each individual healthcare worker and say to them on your team, what is the one, administrative burden that you carry that you want to just eliminate? Let's start with that. And what if we could just, there was a book years ago, 10% happier, I think it was. What if we could improve healthcare by 10% by eliminating 10% of the administrative burden, not delegating, eliminating 10% of the administrative burden? Imagine how much better it would be for everybody. So I've just kind of given you some of my ideas around from a processing perspective, and then also moving forward. And we've developed this national model now, and a national program called All In Caring for Caregivers. You all helped us out with that. Thank you very much. But that's our program. That is our program, is to help organizations go through that exercise at caring for caregivers. And that's what I think is the starting point. There are so much to do, and there are organizations that help once health systems start to mature in their work, but so many organizations are at the starting point. And what we've developed is that little starter kit that comes with your new appliance. Here's the first four. Here's how to turn on your iPhone. So we're at that level, but that's, to me, what organizations can and should be doing right now. And that's all the data is showing. This is what needs to happen.
Yeah. It's so interesting when you speak about the idea of finding a big burden and focusing on it and all the downstream impact. And what's equally important is communicating. You spoke, we responded, because I've been with organizations that have attacked a burden but never sufficiently communicated it. And a year later, nothing has really changed. And you ask the clinicians, did you realize this happened on your behalf? And they go, not really. So part of it, I always call that buying somebody a Christmas present, but not giving it to them. And so part of it is this constant communication coupled to witnessable action of you listened, we listened, we responded.
Can I just jump in there for a second and just say thank you for reading off of my cue card and saying that? Because what I think is different for healthcare leaders on the communication front is that we're so programmed to talking about and communicating about the impact on the patient, not the clinical team. And so we need to pause a beat and say, we did this because we're listening to you, and this will enable you to spend more time with patients and do your patient care work better, more effectively, with a higher degree of quality. But I thank you for saying that, Steve, because communicate. It needs to be done. It has to be done, and it's effective.
And I think I was speaking with a group of healthcare leaders yesterday, and I said, what is your big rock goal? I mean, if we're successful in a journey, and this particular CMO said, for our care team members to say, this place is amazing. I said, great. Then we've got a big beacon on the hill, of which there are many strategies to achieve that. Listening and responding, peer support are some of those actions. The other question I have about peer support, because I think that the formal peer support of having a place to turn that is a peer when a tripwire is hit and the patient is bleeding. The other interesting thing about peer support is building a broader culture of we are there for each other. And Mark Hertling, one of our faculty members for leadership development, speaks about having a battle buddy, somebody that is connected to you, that there's real safety around. And General Mark Hertling talked about battle buddies for new recruits going through boot camp who are 18 years old, haven't experienced much of life, who are now getting a new haircut and lots of different accountabilities that they've never seen before. And to get through this journey, he said the battle buddy, which is there is somebody you can always turn to. And the idea and the notion of building an organizational culture where we take care of each other. We check in on each other. We text each other. We go out for beers together. We have a fantasy football league together. We celebrate each other's birthdays. We cry on each other's shoulders. We laugh together. We sometimes tease each other. There's this sense of family and love within the clinical unit, I think is also an important attribute that organizations can pursue in addition to the formal peer support for the hemorrhaging caregiver. And I would love to get your commentary on how do we turn a dial on building a sense of team, esprit de corps, family, and collaboration as a countermeasure to despair and loneliness and burnout, in addition to reducing administrative burden.
Well, so some of it is very, a lot of this is very tactical, but I was giving a talk to a national group of physicians in a society of pediatric urology last year, and they had lost a member of their community to suicide. And what did they do, Steve? They just said, every member of our national society is going to have a battle buddy. That's what they did. It was not overly scientific. They didn't study the heck out of it.
Right.
What did they do? They assigned a buddy.
Right.
And, what a simple solution to change, immediately change the cultural norms around doing this all by yourself.
Right.
So I think that you have confidential peer support programs and you can train people in confidential peer support. But as you were just talking, I talk about it as a culture of peer support. And that's exactly what you're saying is let's look out for each other. I had this moment in, I guess it was the fall of 2021, and this very seasoned neurologist found me after I spoke at a meeting, and he said, "I've got a question for you." And this was a contrast to peer support. He said, "Corey, I think I understand the timeline of Lorna's passing, and I want to ask you a question." And I said, "Okay, sir." He said, if one of her colleagues had recognized her condition and had tapped her on the shoulder and said, "Are you really okay? And I don't think you are, so let's do something different today. Let's take you home." He looked at me and he said, "Do we even know each other?" And, like many conversations I've had over the last few years, my eyes welled up and I said, if it's a culture where you're looking out for each other and you're tapping each other on the shoulder when Steve walks into a very busy shift and Steve just looks off, and you tap Steve on the shoulder and you say, "Something looks off, Steve. Let's have a conversation. Let's go for a walk. This patient can wait 5 more minutes. They've already been waiting an hour." It could be life-saving, and it's certainly culturally different. And this was this very seasoned 70-plus-year-old who was just wise, and I hadn't thought about it at that basic a level. And so I think some of this, like I said, some of this is simple, some of it is cultural change, but it takes practice. One of the other structural things really quickly that we know is very effective, and it was modeled it was adapted during the pandemic from the military, was a program called Stress First Aid, where you map stress injury to colors. Colors shouldn't be stigmatizing. We know they can be, but they're not. They shouldn't be. And basically, you map a stress injury to what color you're feeling your injury is, that day. But what I've seen clinical care teams do is they get together and they create a process at the beginning of a shift where everybody just registers on a board what color they're registering that day. And I've heard so many examples now of where somebody puts they're looking fine, but they say they're in the red, and the whole team calls a timeout and they go, well, A, why are you at work today? But B, what can we do to help? And, it's just these little tiny micro moments, these little practice, and it can be reinforced through structural elements like that.
One of the things that I would contend, and there's pretty good literature behind this, Stephen Treziak in his amazing book, A Wonder Drug, speaks a lot about this, about the power to both the recipient and the giver of moments of kindness and help. The human soul is designed to make a meaningful difference. It across every culture, that seems to be the transcendent property of the human condition, is I am doing something that is helpful to something. And there are infinite ways to have that manifest. And the idea of building a culture where we look out for each other, text each other, tap each other on the shoulder, and just eyes wide open for a colleague who may be struggling. And we begin to train and develop those properties as a part of being a care team member here. And we train and develop our leaders to lead with vulnerability and to lead with compassion and listening and responding and modeling behavior and outfront leadership. It can be incredibly powerful to turn those cultural dials. And then all of a sudden, a year or two later, you go, is this different here now? And the funny question about the KPIs, I think it's the process of, KPIs are children of the mission of creating an amazing place for the lives of those that are providing care. They're not the parents. They are the consequence of our mission. And that inversion is that process that we call surrogation, when the metric becomes the mission, which almost bastardizes the whole thing. Like we're trying to wag the dog. It's like, improve our patient satisfaction scores. No, kindness and compassion and clarity of communication and trust with every patient every time, the scores will take care of themselves. So,
Exactly.
I know we're running out of time, and
Yeah.
I forgot we're on a podcast. So
Okay. We're just chatting. We're just having a nice chat. We haven't talked in a little bit.
The last thing I want to speak about that I think we have accessibility to. We have accessibility of being the kind of leaders that can help lift, support, and respond. We can be a teammate that helps support and lifts. We have access to those things. We also have dominion over who we are for the patients that we serve. My personal journey was when I began to impact the patients in a meaningful way and hear their story and know their story and what matters to them. They gave me feedback loops that juiced me in terms of my sense of purpose. So there's power in not in a patients come first sort of way, but delivering meaningful impact to the lives of the patients that we serve is actually the best of medicine. So we call it connecting, collaborating, and leading, as in all the things that you and Lorna Breen Heroes Foundation speak of. One final question that I have for you as we close is, you speak about the quick start guide of how you're starting, and nobody needs help starting an iPhone, so you need a better metaphor. But
Talk to my parents.
So take us through quickly the elements of the quick start guide, just so people can get sort of if they want to join the All-In campaign and if they want to begin to participate in that journey, what actions they might be able to take, and what that quick start guide might look like for those that are looking for.
Absolutely. So we were talking before about burnout as an occupational syndrome, and we know that when I draw my Venn diagram of this issue, and it's on our website, between burnout and depression, that on the mental health, because occupational disorder is not a mental health condition, you do have these mental health conditions that need to be taken care of. And the only way to take care of mental health conditions is for healthcare workers to get formal help. And there are so many penalties right now, perceived and real, that occur in these questions on credentialing applications and licensing applications, which stand between healthcare workers and getting mental health care. They've recently been identified by the American Hospital Association in their suicide prevention guide as the primary driver of suicide. So we know that these issues exist. So what we've done in our starter kit is we've actually started there because this is something that every hospital system, every licensing board, every insurance company can do very quickly using our 3-step free toolkit on our website. It's also embedded in our starter kit on caring for caregivers. So step 1 is we have you use our toolkit to evaluate, change, and then communicate the changes to your workforce so that they can start to see that they are valued and supported. And if they ever need mental health treatment, boom, they can get it without repercussions. We have now identified and linked a national badge to that. So it's the All-In Champions Challenge badge that organizations have. And we've just published our most recent map on medical licensing today, and our map of 75 plus hospitals that now have this badge across the country. We published that on our website today. So that's step 1, phase 1. Phase 2, we want to make sure that healthcare leaders really understand what's going on, and they develop a common vocabulary to understand the root cause and the solutions. So we then put them through a digital curriculum, which you all helped us create through Practicing Excellence. Thank you very much. It's called Wellbeing 101 course, and it uses micro learning techniques very similar to the Practicing Excellence methodology, and it puts organizational leaders through a short course on this work. And then that course culminates and leads into phase 3 with an operationally focused 12-month action plan for those leaders. So at the end of phase 2, you are asked to develop, you're given templates, and you're asked to develop this 12-month action plan in any of these drivers of burnout. Now we've moved from mental health to burnout, and you are put then into learning collaboratives based on subject matter as well as role in your organization. And these are developing and scaling across the country right now so that organizations can learn from each other about what's working. So it's a 3-phased program. Those are the phases. We have every hospital system in Virginia actively going through it right now. We have a very large medical group that has 900 hospitals that their clinical teams work in going through it. And we have another large state of hospitals going through it right now, or about to go through it with us right now. So it's scaling very quickly, and we're really thrilled for our partnership with you all, as well as all those other supporters we have out there and making this happen. So.
Well, I think, again, I'm grateful to you as the rainmaker you are, again, your amazing wife, Jennifer. And there are unimaginable losses that are even beyond the scope of words that sometimes create gardens that never would have emerged otherwise. I recently met the mother of a woman whose son was lost in a motorcycle accident. And I was just dreading running into her. It was at a fundraiser for her. And she, like you, spoke of the amazing purpose-driven work and community events and incredible things that have happened as a result of that unimaginable loss. And so Lorna Breen is looking down and looking at the garden that's emerged. We've got a lot of tilling yet to do, a lot of watering to do.
Thanks.
Because we've got a burdensome system, but thank you to folks like you, and we're right beside you. How do we develop people to become their best and to love their life? So, my brother, I'm grateful to you, and thank you for being here, and I love you for all that you do and who you are.
Right back at you, man. Thanks for the opportunity, and thanks for the conversation, and thanks for your listeners and viewers. I don't know what we call these people who are watching us, viewers, for paying attention today. And please feel free to reach out if we can ever do anything to help. So thanks.
You bet. And we'll get a copy of the segments of the podcast out to the listeners. But thank you,
Sounds
Corey.
great.
And
You got
we are out.
All right.